Hello and welcome to the program. I'm your host, Neal Howard, here on Health Professional Radio for this Health Suppliers segment. Thank you for joining us today. Our guest in studio is Medical Director for the Center for Successful Aging at MedStar Good Samaritan Hospital. And he's here today to discuss with us the importance of recognizing and treating depression in our geriatric population. Welcome to the program, Dr. George Hennawi.
Thank you, Neal.
Thank you. Thank you for joining us today. Now, as medical director for the Center for Successful Aging, I've not heard of a department of a hospital named as such. Give us a little bit of background about yourself and talk about your role there at MedStar Good Samaritan.
I'm a geriatrician by training. I'm the director of the Center for Successful Aging, and just to give you an idea about the center, it's an outpatient practice. It's a doctor's office. But it's a new model of care for our aging population. We deliver what we call a person-centered approach, a holistic approach to care that involves not only the clinical aspect of care, but the psychosocial, the mental health, the functional aspect, the family aspect, the caregiver aspect, hoping that we can deliver a better quality of care, better quality of life, and serve our patients in a different way, which we believe it's the way they deserve to be served. The center has been established for about 3 years, and we have served about 1,000 elderly, and we're hoping to continue to serve our community in the MedStar Good Samaritan area.
Impressive. Is that 100% outpatient?
That is correct. It's a very holistic approach in a doctor's office, as I mentioned. So when you're here, you will see an interdisciplinary team engaged with every patient, a social worker, a nurse and a nurse practitioner, a physical therapist, a pharmacist, and a physician. And we work closely with subspecialists, a geriatric psychiatrist, a urogynecologist, an endocrinologist, all to serve our patient in one location. So our patient don't have to go to many, many places. They sit in the room and we bring the services to them.
So you're talking about not the traditional 5 minutes in and 5 minutes out with your physician. They're there for a good period of time getting a complete workup and how their care needs to progress in the future.
That is absolutely right. For us to impact care, we believe that we have to start recognizing and addressing the person. And when you want to address a person, you need to recognize and get to know them on personal levels. You need to know how their house environment is. What are their social barriers? How are they doing from a mental health and emotional perspective? Are they functional or are they at risk of falling? And that takes beyond 15 minutes, as you know, and as you mentioned. Our new visit is about 90 minutes, where the patient will see main interdisciplinary team members, the social worker, the nurse practitioner, and the physical therapist, the pharmacist, and the physician. And our follow-up visits are anywhere between 45 minutes to an hour, and they're very intense. We try to understand what our patients' values and preferences and let them drive the way we care for them.
Now, once you've been working with a patient for a time and you realize through this extensive hands-on approach, this holistic approach, that there are some, as you said, some mental health issues that are going on. Maybe dementia is setting in, or simply maybe the depression associated with aging. Talk about identifying depression in some of your patients in this outpatient holistic fashion.
It's a great question, and be honest with you, depression is a big deal in older folks. I believe, if I'm correct with the number, about 6 million elderly Americans have depression, but about maybe 10% of those folks are treated for depression. The model that I mentioned to you allows us to detect depression very early, even if it is not visible to the person that has it. And what I mean by that, so many of our older folks, they get depressed, but they kind of say, well, this is part of aging. Well, you know what, I have diabetes and hypertension, and I had a stroke before. That's why I feel the way I'm feeling. Or sometimes it's a bad stigma, so they just don't want to say I'm depressed. We use, through our holistic approach, through our interdisciplinary assessment, we use certain scales that allow us to detect depression. And those scales are validated, so they have a good sensitivity that if the person is depressed, we're going to get positive answers. And based on those scales and based on the communication that we do with the patient and their family members, we recognize, let's say they have depression, and we connect the dots that, if you're depressed, you're not going to be able to manage your diabetes and high blood pressure. And at the same time, we don't want you to think that the way you're feeling is part of aging. Aging does not necessarily mean you have to be depressed. You pointed out to a key point, and that I'm glad you did, which is dementia and depression. Sometimes dementia can present itself like depression, and depression can present itself like dementia. So many folks with dementia will experience depression because of those degenerative changes in the brain. But it's very important to differentiate the two, and it's very important to kind of screen for both and direct the right approach to the right diagnosis, and that's what we do.
Does your model identify problems associated with depression, no matter what those problems may be, simply by asking the right questions, the right probing questions, or simply listening to the patient and the caregivers, and as you mentioned before, connecting certain dots? When those dots are connected and you see a problem, say, with your patient's environment, how far do you go there at MedStar to get them placed in a more conducive environment to less depression or no depression at all?
Yeah, so I think it's another great question. So you identified depression. You and the patient and their family members identified depression. How do you get to that conclusion, and how do you modify the environment to fit such treatment plan? And I'm going to dissect it to the first piece, which is how do you identify it? And I mentioned to you we use certain tools. Those tools ask questions beyond just, are you depressed, for example, because so many people will say, no, I'm not depressed. Those questions will go to say, have you dropped off any of your activities that you used to do and you used to love to do in the past? Do you feel that you're hopeless? Do you feel that you're helpless? Do you feel worse off than other people? Are you better off dead or alive? How does your future look like? All those questions kind of dig deep into the emotions that will allow us to kind of say, even though the person is saying I'm not depressed, but you know what? 7 out of those 10 questions are positive for what looks like depression. We confirm it with a family member or somebody else, and based on that, we kind of create our conclusion of the diagnosis. So now that we made the diagnosis based on the validated questions and the interaction between us and the patient and their family, we try to modify the environment. And what I mean by that, some depression might be related to the fact that an elderly is isolated and just not interactive and not going out, or some of it is related to, they do have medical illnesses and they're feeling tired, and that fatigue is impacting their emotions and how they're doing. So we work with them on changing that by either connecting them with some programs that we have here at Good Sam or at MedStar in general, where we can work with them on counseling. We can work with them on getting out and exercising. Exercise will lift the mood up. We work with their family members on bringing attention to the fact that, mom or dad are kind of lonely, and maybe going out with them twice a week or structured approach to socialize with them will help them out. And we kind of provide the resources to support them through this whole endeavor.
And, if I can point out, one of the very unique things about this model is that, say these test tools rule out depression and the person is genuinely not depressed, maybe it can identify the actual problem, and you don't have to send them someplace else. You can address that particular problem now that depression has been ruled out at the same facility.
That is correct. And most of the time, after we rule out depression, for example, it allows us to focus on the other entities that you're mentioning. Sometimes the person is feeling this way because they're developing early dementia. We pick up on that through our screening. But sometimes they're feeling this way because they are on multiple medications that are making them tired or feeling bad. We target the medication, or we target obstructive sleep apnea. You're absolutely right. Rule out depression, rule out dementia, and then target other entities that can lead to such feelings.
Now, what type of resources are available through MedStar Good Samaritan Hospital online?
Online, I think we're, if I can, I don't know if I can speak for everybody, but I will tell you what we try to do. Our website has some connections to resources, such as, for example, psychotherapy. We have connections to community partners that work with elderly on whether transportation to a place where they can get the services, or local approaches to care in their own homes and services in their own homes. We have resources on the line of a center right next to us called the Good Health Center, where they bring elderly to the center and work with them on an exercise regimen, and then they work with them also on lectures regarding anxiety and depression, and connect elderly together. All of those are available, and the family members, if they have the ability to go online and take a look at them, they can connect those dots and, with our help, get their elderly to the right location.
Right. Now,
or right services too.
www.medstargoodsam.org.
That is correct.
Great. Okay. It's been a pleasure talking with you today, Dr. Hennawi.
Thank you so much, Neal. I appreciate the opportunity.
Thank you. You've been listening to Health Professional Radio, this Health Supplier segment. I'm your host, Neal Howard. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. You can listen in on SoundCloud and subscribe to this podcast on iTunes.